Now we get into our second session, a proper regular session, because the first one was basically just getting down to the declaration, what's the update, what's happening, and now we get down into specific topics. So the first topic is patient-centered care in NCDs. So I would now invite the chair of this session, Jolanta Bilinska. I think most of you know her. She is the president of the Patient Safety Foundation Poland. She is also the founding board of director of World Patient Alliance. She is the treasurer of the World Patient Alliance, and she is also among the first batch of Patient for Patient Safety champions by the World Health Organization. So I invite Jolanta to please chair the session.
Thank you very much. Our session has the first speaker, which is a honorary advisor from International Society for Quality in Healthcare, ISQA, Anna Edwards. Please, Anna, join us.
Yeah, she's coming. You can just introduce Anna.
Okay. Anna is a passionate patient advocate. She spends over 25 years navigating health and social care systems in the UK and overseas. She has complex Crohn's disease and has undergone over 30 major surgeries, as well as a multitude of their other complications due to her condition. Anna started her career as a criminal barrister and practiced for almost 10 years before deciding to change direction to work in healthcare. She has since worked in a variety of roles across regulation, central government, and commissioning, is currently Associate Director of Transformation and Change at the Regional Ambulance NGS Trust in England. Anna is also board honorary advisor on person-centered care and co-production and the International Society for Quality in Healthcare, ISQA. In this capacity, she has spoken across the world on the importance of patient voice, chaired a number of webinars, and supported ISQA to set up a new education program on person-centered care. She lives in a rural part of Kent, England, with her husband Tom, son Dara, and Labrador Basil. So the floor is for Anna. Please join us. She will stay here.
Okay, so this is what this session is about. Putting patients at the centre, as we know, requires confronting the barriers that stand in the way, for instance, entrenched systems, limited patient involvement, and resource constraints. Today, we're going to talk a little bit about best practices and my lived experiences, hopefully providing inspiration and guidance on how to advance truly patient-centred care in spite of these challenges. So, I want to start with this definition, which a wonderful colleague of mine, Professor Paul Batalden, has outlined. He works at the Dartmouth Institute in the US. I've been really lucky to work with a lot of the guys there, and they've got a wonderful centre focusing on person-centred care. And what Paul says is co-production and person-centred care is the interactive work of users and professionals in the design, creation, development, delivery, assessment and improvement of the relationships and actions that contribute to the health of individuals and populations through mutual respect and a partnership that notices and invites each participant's unique strengths and expertise. It's quite a lot in there, isn't there? But anyway, hold that thought for a second. And I'm going to tell you a little bit about one of the interactions I've had with the healthcare system. So in 1996, I was diagnosed with Crohn's disease. I was at university at the time in Manchester, and I had to leave following surgery. It was the first operation I'd ever had. And over the following 25 years, I've had multiple bowel surgeries. Many of them have been life-saving. I've suffered many different complications over the years, encountering sepsis, pneumonia, MRSA, anemia, the list goes on and on. And in 2010, I met my husband, and about 5 years later, we decided to have a family and try and have a family. That wasn't straightforward because of all the surgery I'd had in my pelvis. So we took professional advice and eventually decided to have IVF or fertility treatment. At this stage in my life, I thought my difficult health journey of many surgeries was behind me, but sadly, that couldn't have been further from the truth. We started the IVF drugs, blood tests, and like everybody else in that clinic, we were really, really excited about the possibilities. Sadly, though, I ended up with something called ovarian hyperstimulation syndrome, which is normally completely treatable. But because the organs in my pelvis were unable to move due to previous surgeries and extensive scar tissue, I hit really serious complications. I began to feel incredible pain in my back, so I called the hospital and I was told to take paracetamol. I explained that this pain was like nothing else I'd experienced, that I was no stranger to pain because of my previous medical history, and I also had no interest in being in hospital. They still told me to stay at home. So at that point, my husband and I made the decision to drive the 2-hour journey to St Thomas's Hospital in London from our home in Kent. And by the time I got to the hospital, I was hardly conscious and I was whisked through the ED. So I knew there was something really clearly wrong, because in England, no one gets whisked through the emergency department. On the ward, I remember very little, except the urologist coming to my bedside and telling me that my ureters had been blocked by my ovaries and they had no easy answers to unblock them. He explained that if they weren't unblocked, I was not going to make it through the night. And at the same time, I received a call from the fertility clinic to tell me that my embryos in the lab were doing really well and they hope to have a significant number to implant in the next phase of the IVF process. Things were pretty lucid at this point, and the next I knew, I was being wheeled into the basement of the hospital to have interventional radiology, to put something called nephrostomies or stents into my back to try and drain my kidneys. I was awake throughout this procedure. It was done in the early hours of the morning. I still remember it very well. And I can still visualise laying on my front and looking at the lines of stents hung up in front of me whilst I was in extreme pain. And I'm sure others in the room who've had surgeries or different procedures done will have some understanding of those memories that you just retain for some reason. Back on the ward, it became clear that I was suffering from a kidney infection, which had been aggravated during the procedure. And as a result, my heart rate rose to a dangerous level and the crash trolley was called. I'm loving this musical intervention. The next I knew, I woke up. I was overlooking the beautiful Houses of Parliament in London. My husband was snoring beside me on a mattress. And they'd allowed him to stay, which is generally not accepted practice in our NHS, but I think they knew the situation was very serious and there was a real threat to life. And that team had saved my life. And whilst I had stents for a couple of years, it was a small price to pay. And for those of you who are interested, I did implant the embryos, but nature knew best. I didn't fall pregnant. My good friend then acted as a surrogate for me, and whilst she did fall pregnant, she sadly miscarried. These were really dark days. Remind me to tell you at the end, because I've taken the slide off, what the outcome is. But that's our case study, okay? That was me 8 years ago. So, how did co-production work in this scenario? You might think that doing co-production in such a situation is, almost impossible. But I think you'd be wrong. This is what the care team did for me that evening to co-produce. They were completely honest with me about what the outlook was. They built trust with me really quickly so that they could have robust conversations, noting that I was a patient with chronic disease, with extensive knowledge of my own condition. They outlined the options and the risks and gave me time to ask questions. This is really important. As I said, I was lucid, right? So they involved my husband when I was unable to communicate so that he could be my voice. And they let him stay. So they respected my husband's needs as well as my own, as they mattered to me. No decision about me without me, Padilla. That's exactly what we're trying to achieve. So looking at Paul's definition at the beginning, Professor Paul Batalden, they were interactive. There was mutual respect. They partnered with me and my husband, and they invited our expertise and strengths and the knowledge I had of my own condition. So here are some things to consider when you were trying to co-produce, even in the most critical or challenging circumstances. We're not looking at paternalism, we're looking at partnership. Transactional focus becomes the go-to, particularly in really critical situations. We don't need to be transactional, we can continue to be relational. One-way communication can be very difficult, so continuing to have a dialogue, whether it's with the patient or their loved ones around them, is really important. And shared decision-making is the absolute golden standard. But we know co-production can be difficult, and this graph is a really good depiction of the power sharing involved. You can see on it, there's the need sometimes to keep power, sometimes share power, and sometimes cede power, with the latter being true co-production. In most healthcare settings, there are performance management targets, but these alone can be damaging, as the focus can move us to the target and away from the patient. In many settings, there is quality improvement where professionals might consider a complex problem and look to solve it without asking those affected what they think. They're sharing the power to a certain extent because they're trying to do what's right for the end user. But the real silver bullet as a healthcare leader or professional is to have all three of these elements at play. There is performance management, there is quality improvement, but there is also co-production. We are asking the end user, we are authentically involving them, and we're acting on what they tell us. Leaders and healthcare professionals that can operate under all three curves are comfortable with complexity and generous with power. I think in the situation I outlined, we were sharing power, and arguably ceding power may have had dire consequences. So there are decisions to be made in the quest to co-produce all outcomes, and it may be that power sharing can be fluid over the course of an episode or connected episodes of care. I'll tell you something else about the night that my kidneys failed, which I found out later. The interventional radiologist had wanted to postpone the nephrostomy procedure until the following day, as it was a Sunday evening at the early hours of Monday morning. My neurologist had to instigate a hierarchy and demand action, stating that I would not be alive in the morning if the procedure was not done immediately. This was clearly the consultant keeping power. And he wasn't involving me at all. But it ultimately saved my life. As medical professionals, therefore, sometimes decisions just have to be made. One has to use their intuition. And whilst striving to co-produce in all circumstances is important, recognising when safety must overrule the concept is also key. But let's not forget the telephone call I made at the start of that episode of care, when I explained to the team that I was in extreme pain and something wasn't right. Was that co-production? Being ignored, overruled? There was no interaction. It was incredibly paternalistic. It was transactional. It was one way, and the power was retained by the healthcare team with no respect at all for the knowledge I had of my own condition. We've talked in the case study I've outlined about the consultant retaining the power in my best interests, and this had a positive outcome. But the same equation can lead to a very negative outcome. And if I'd not made the decision to ignore the advice I received on the telephone, I fear I wouldn't be here to tell this story. This is another really helpful model. This is the Montreal model. Some of you might be familiar with it. It's an excellent way to show the different ways healthcare professionals can deliver care, whether it's to the patient, for the patient, or with the patient. And it follows similar principles to the third curve concept. But I suppose I'm going to skip over this in the interest of time, but I would ask you to think about how you get closer to the right-hand side of this model. But do look it up, because it's a great way of looking at co-production. The theories are important, however, we also have to consider how we bring co-production into practice. This is a white paper that was written by my ISCWA colleagues in 2022, and whilst it's currently being updated by myself and others at ISCWA, the principles remain strong. It outlines how to build person-centred care information flows, paying attention to our concepts and language. Person-centred care terminology is not new per se, but it is currently not part of documentation and regulation signals in most healthcare systems. The following three concepts are central to person-centred care feedback loops. Firstly, the person. So the identity and the person's narrative, what matters and why. Putting words to identity prevents professionals from making the errors of ignoring the person, the patient. Making it more personal introduces a level of humanity into the interactions that protects us from treating each other as mechanics. Then we have the goal, what matters to the person and its translation into relevant goals. This drives decisions in the patient journey and is the basis for evaluation of the journey. Careful documentation of what matters directs prioritisation and tailoring of the patient journey. And then we have the patient journey itself. That's the plan and the actual delivery of care that should ideally embed what matters as an outcome and reflect strong self-management as the core of the care process. The patient and professional co-create the plan and its delivery so that the journey is meaningful, feasible, effective in reaching its goal, and is as comfortable for the person as possible. The patient journey documentation may include a patient journey narrative as part of the history and the patient experience feedback. The care plan, seen from the patient perspective, should outline who does what and when for all the patient's conditions, and should also document what's already been delivered and what is upcoming. Suppose a critical element was not executed as planned. In that case, this fact should also be documented, together with a review of why it didn't happen and how to re-establish continuity with the patient journey. But we're not here just to talk about person-centred care today, because we're also interested in how it applies to non-communicable diseases. And I really like this quote by Dr. Hans Kluger. It says, NCDs are not just preventable or treatable, they're also largely ignored. Yet the truth is, if NCDs were a virus, the world would be in lockdown. That's incredibly powerful. I think Penella might have read out some of these points earlier, but they're also really important. NCDs remain the leading cause of death and disability in the world, including in our region. In Europe, 1 in 5 men and 1 in 10 women die before the age of 70, as Penella said, because of NCDs such as cardiovascular disease, cancer, respiratory disease, and diabetes. Each year, the European region sees 1.8 million avoidable deaths from NCDs that are either preventable through effective public health measures or treatable with timely access to quality healthcare. Of these, 60% are linked to preventable causes such as tobacco and alcohol use, high blood pressure, unhealthy diets, obesity, physical inactivity, all of which can be addressed through stronger public health policies. The remaining 40% are from treatable causes where death could be prevented or delayed with timely diagnosis and access to quality care. Progress in reducing premature mortality from NCDs has been derailed by the pandemic that we all understand and went through. Our region is off track to meet the global NCD targets for 2025 and 2030. Nearly 2 million deaths from NCDs can be avoided every year with better prevention and treatment. And while gaps between countries have declined since 2010, stark disparities still remain. And then in the region, this is massive, productivity losses linked to these NCD deaths are estimated at over $514.5 billion each year. So despite clear evidence of high returns on investments, funding for NCD prevention remains critically inadequate. 10 countries in our region have already achieved the 2025 target of a 25% reduction in premature mortality from the 4 major NCDs for both. I'll tell you in the interest of time, because otherwise Yolanta will tell me off for taking so long. Belgium, Kazakhstan, Denmark, Estonia, Israel, Luxembourg, the Netherlands, Norway, Sweden, and Switzerland. No surprise our Scandinavian countries are in there because they are leading the world in so many different ways. But what they've done is they've implemented the World Health Organization best buys. These are really, really important. They're bans, taxes, behavioural change. I was thinking about behavioural change when you were talking, Penella, about can we reach some of these targets? I think we can, and some of the answers are quite easy. They're proven cost-effective measures to address NCDs. I'm not going to read out the rest of that slide, but you can see the point. So how do we manage NCDs from a person-centred care angle? Well, the World Health Organization also gives us the answer to this, albeit from a patient safety perspective, but the arguments are still true. We engage patients, we build the capacity of patient advocates and champions, we establish openness and transparency, and we provide information and empower patients and families. But why engage patients at all? Why bother? A bit of a pain, aren't they? They just want their voice heard, and actually time is money, and we don't have the time day. We've got so many patients coming through the door. Well, here's why. It improves clinical outcomes, less emergency department visits, and you're likely to have better adherence to medication and treatment plans. There's a higher care satisfaction with patients often choosing options that are less costly or invasive. Patients are more likely to engage in positive health behaviours, and staff are likely to have better morale and performance with increased patient engagement. That's a study done by the Health Foundation in the UK, which many of you will be aware of. And what other benefits can we expect? Well, a better sense of belonging, social relationships. We can create better peer support networks. We can improve other outcomes like employment and education. And services also become more affordable and sustainable. So if it's such a positive outlook, what are the barriers? And I suppose the enablers to person-centred care. This is a great study that was done in 2017, I'm sad to say, because that's almost 10 years ago. But it makes clear that person-centred care has the potential to transform patient care and clinical practice. However, for it to be successful, there needs to be a power shift and a mindset change to allow the space, time and opportunity to focus on the narrative and partnership. Explicit and consistent leadership is facilitative and essential. The majority of researchers in this study describe leadership styles as informing person-centred care, where they've instigated organisational change, emphasised person-centred care values and working practices, and interprofessional team working. Leaders prioritise person-centred care as role models and forerunners, and consistently working in a person-centred care way. Secondly, researchers cited the importance of interested staff and a committed group of professionals with a positive attitude that allowed for trust and partnership building. Successful implementation was dependent upon professionals' skillfulness shown in listening in a different way to patients, confirming, documenting, and repeatedly acknowledging the person's narrative. Seeing the patient as a person who is active and capable, or being an equal partner, was cited as a common facilitator. For several of the researchers, insufficient time constrained person-centred care delivery. We hear this all the time, don't we? I haven't got time to do all of this. It did take time to participate in training, education, and develop partnerships for professionals and patients. Similarly, professionals needed to learn new communication techniques for patients with communication disorders or work with older migrants through translators. The fast pace of healthcare activities in some contexts made person-centred care implementation really difficult. However, this is important, once embedded, several of the researchers described how person-centred care actually saved time when patients took responsibility for their own care or when a person's goals were effectively elucidated and supported. Researchers identified barriers specific to the development of person-centred care interventions, including recruitment, study population, research design and setting. This included having to recruit reasonably symptomatic patients and feeling an obligation to find interested professionals. A high turnover of professionals and workload in nursing homes, for instance, restricted the professional participation. Researchers were working with a population with diverse health problems and needs. For example, patients with psychosis experienced decreased autonomy and insight with goals that might be dangerous or unrealistic. A vulnerable study population also proved a barrier to person-centred care, where patients were aphasic and or frail, acutely ill, sedated and undemanding. Similarly, the partnership and narrative components of person-centred care were demanding when working with people who mistrusted officials based on previous encounters and language barriers. I'm not going to go through the last 2 points in the interest of time, but it's a really good study and worth reading. So where is person-centred care working really well when it comes to NCDs? Where can we go for some best practice? Well, the RHZ in Maastricht is an umbrella organisation for all 89 GPs in Maastricht, which has a population of 170,000 people. This organisation was established in 2006 to redesign diabetes care in the Maastricht area and has subsequently extended to other long-term conditions. RHZ grew quickly after national policy was introduced to improve the care for people with chronic conditions, through which integrated payments were developed for specific disease treatment combinations. Multidisciplinary integrated teams involving GPs, nurses, hospital specialists and other clinicians are now the norm in this area. Only care for severe and complex diabetes is now led by hospital doctors. They're obviously moving tables out there. They haven't been able to scale this throughout the Netherlands, but I think it's a really interesting model and it does take the pressure off our secondary care facilities. The National Institute of Health and Care Excellence in England is another example. They use patients on all pathway design groups. I spent 3 years on one pathway design programme on acute medical emergencies and felt very much part of the team with a very equal voice. Patient, family and care advisory councils are popping up all over the world. My colleagues in India at Sri Ranga Hospital now have active PFACs and have implemented EBCD in a variety of departments. In the dialysis department, they've experienced an almost 50% increase in patient satisfaction after EBCD was introduced, and a 25% increase in staff satisfaction. So really compelling stats there. And then there are obviously organisations focusing solely on patients across the world. Obviously, we have the World Patients Alliance based in the US, but supporting all of us across the globe. There's the Beryl Institute in the US and others. You've got the World Health Organization Patient Safety Programme, which is an active international group focusing on patients. If you're not members of that, do join it. In England, we've got National Voices, we've got the Patients Association, and I'm here today, obviously, as the honorary advisor to the ISCL board, who have person-centred care represented in everything they do. The challenge, I suppose, is how do we combine our knowledge and experience? And I think that will always be difficult because there are so many of us trying to aim for the same target. So finally, then, recommendations for actions from me. I feel that healthcare organisations should embed patient voice in service design and delivery from board to ward. They should offer training and appropriate remuneration to ensure equality of perspectives. If that doesn't happen at the moment, patients are often given their time voluntarily, and that's not, in my view, acceptable. Patient organisations are advocating, sorry, I haven't moved on my slides, have I? For stronger patient-centred care policies, but they need to come together and have a stronger combined voice on what matters and affects patients all over the world. And then finally, patient organisations and advocates should work to influence international and national policy. Again, it was Penella's point, wasn't it? Go and speak to your government. For instance, the upcoming UN high-level meeting declaration where positioning patient-centred care as a cornerstone of NCD management, that's a really key opportunity. I promised to come back and tell you what happened. Yeah, I didn't end up having a child of my own, but what I did do 7 years ago was adopt my gorgeous little boy, who is now 7 and sitting at home having had a lot of trick-or-treating last night. But he is the centre of my world, and actually, in hindsight, I probably would have gone down that route and not compromised my health if I knew I was going to get such an absolute legend of a boy. But everything works out in the end as a patient with chronic disease. Thank you very much.
Thank you very much for wonderful presentation. Don't go out because, we are also online, and many participants ask about Anna's presentation. I just tell you. So first question. You have a long history of being a patient with Crohn's disease and have learned a lot in this time about navigating complex health system. What one thing would be to suggest to others when it comes to successfully co-producing patient outcomes? First question, please.
Well, I think it's communication, actually. It's a really easy one, and working in the NHS at different levels. It's the one thing we talk about a lot when we're designing systems, but it's also relevant to co-production. It costs nothing, but it enables you to build trust, create safety for patients. And also communication as a patient is important because that enables you to feel part of the team. It enables you to get your views across. So I would say communication is the absolute starting point for co-production in any business setting.
This also. One last question more. With your condition, did your doctors advise you of possible complication with the pregnancy?
Yes, they did. Absolutely. I was told that it was going to be really difficult, but as a woman who wanted a family, you take them. And listen, I had a lot of surgery by this point. I was a bit of a pro when it came to having surgeries, and therefore, it's not that I wasn't scared. I think it's more that you think you're invincible. You go through so many surgeries and you think, I've been through this, I've been told before I'm not going to survive this. Here I am again, popping up. So I'll be right. But yes, they absolutely did tell me. They didn't advise me not to do IVF, but they told me it would be challenging. More the childbirth part on the treatment.
Thank you. Now you can rest, drink water, and I will invite another panelist, Lucy Lastikova and Linda Reinstein. They are our two next panelists. Please come to us. It is a question for Lucy Lastikova. You like to refer to patients living with chronic condition as managers of their illness. What does it mean specifically?
First of all, hello everybody, good morning. We learned a lot about patients and HCP, but I have encountered with patients that they're bending to easy solutions. I will take a pill and I will be fine. So what I'm always saying that you're responsible for your health, you're responsible for your disease. And it's not only about the rights you have, but it's also about the responsibilities. So as the manager of your health, you need to be aware of what you do and you need to do certain things which are acknowledged that help your lifestyle. So you need to take better care of yourself and then you are allowed to ask for professional help. So
Thank you. And now a question for Linda Einstein. Your son, Alan, was diagnosed with mesothelioma. From your experience, what efforts are needed to make health system more navigable and truly patient-centered, ensure early detection, coordinated care, and equitable access for
When Alan was diagnosed with mesothelioma, we had never heard of the diagnosis before, and we soon learned that asbestos hadn't been banned in the United States. As a result of Alan's diagnosis, I did co-found the Asbestos Disease Awareness Organization. So my comments today are both professional and personal. What I want to share is when with NCDs, many times patients and their families are thrown into a very steep learning curve, and it's nearly impossible to navigate. So not only are you trying to find a treatment plan, but you're trying to survive for your life. So thinking about early detection and awareness, that is something that's really important to me because in a lot of NCDs, prevention is the cure. And I think embracing that knowledge allows us to have better quality of life. As Anna discussed with co-production and others, having a multidisciplinary approach, I think, is very important. I do international work, but if I focus on the US, it is really, the patient is responsible for determining their treatment plan, managing their care, and that at times I think is almost an unfair burden without invoking a lot of other advocates to help with the system. And when we think about NCDs and from exposure to early warning symptoms and then trying to navigate a diagnosis like Anna discussed, had she not pushed forward, she might not be here today. And that happened also to Alan, is that you have to be your own best advocate. But it's not just the patient, it's the entire family. So whether her husband was sleeping in her room or I was navigating for my husband, it does take a village, not to be trite with that, but it's important. And care management is huge. So I think leaning on different organizations and patient advocates is important to recognize that care management is part of the process. Thank you.
Exactly. Again, a question to Anna. If you could change one thing about your healthcare journey over the last 30 years, what would it be?
I think for me, it's variation in care. So I appreciate it will be different across the world, but in England, I can access my regional hospital, which will be 10 minutes down the road from me, or I can go to a specialist hospital in a city. All of my care is under St Thomas's in London, which is obviously a world-leading hospital. But the care I get in that setting is very different to the care I get in a regional setting. Person-centred care is not great regionally. It's not great in a primary care setting. So, but it's really good in the city hospitals, in my experience. So if I could change one thing, it would be to get consistency across, certainly across countries and across the world in terms of what person-centred care means and how that feels to patients. And the way that we do that is by ensuring we've got proper training for our healthcare professionals and for patient advocates and for patients, really, proper information, appropriate role modelling, enough investment in person-centred care. And as I said in my presentation, leadership of the importance of it and the benefits of person-centred care.
Question. In your experience, what is one critical overlooked aspect in the care of perception of people living with chronic? Something that remains under-discussed but deeply impacts outcomes and quality of life.
I would say it's the burden of the disease itself, because when we are talking about chronic disease, it's not something we can cure completely. It's something that we can manage, and it has many aspects itself. The repetition of the disease, one days are being better, some days are being worse, and it affects also the mental well-being of the people, because if you think about it, that you can never be sure how the next days will come, and if you will end up disabled, if you will be socially excluded, if you will be able to have families, if you will have a regular work life career, and especially when you are diagnosed in an early age, I would say that the multiple system of aspects needs to be reconsidered, because every patient in a different part of their lives have difficult needs and different needs, and some doctors are not still able to attract that or be able to realize that what is working for one patient, it's not working for everybody the same.
Yeah, thank you. And Linda, you mentioned before how important is family because mesothelioma affects the entire, not only the patient but also the family. Based on your experience as a caregiver and advocate, how health system can better now integrate families and caregivers into NCD care models to strengthen communication, coordination, and overall outcomes?
So November 1st is Family Caregiver Month in the United States. I don't know if you have that here, but it's important to focus not just on the patient, but the entire family. And caregivers really have to accept a huge burden. I think it's the ultimate aspect of love, but at times it is difficult balancing patient care of a spouse or loved one or your children. And I think from my personal and professional experience with other patients in different countries is many times the physicians don't directly talk to the caregivers. It is a physician to patient conversation. And I think adopting and embracing other aspects of care is really important, because at the end of the day, many times it is the caregiver that is having those direct conversations. I love using AI. It does not replace a human. Let me repeat, does not replace a human, but there are opportunities to use it to ask questions, to put in some diagnostic test results, and to get some answers. And at least I think you can balance what your physician might tell you with another perspective, and you have to challenge that also. AI is not obviously the truth, the mecca, but psychosocial aspects are difficult. When Alan was first diagnosed, my daughter was then 10. So cancer impacted our entire family. And he fought for 3 years to have an EPP, which some of you may know, an extrapleural pneumonectomy, resecting a left lung, surgically replacing his diaphragm, stripping off his pericardium, all for more time. I share those details because I think when we look at the trauma of NCDs, when they're preventable, that evokes a sense of anger at times for all three people. So I think looking at the family as a holistic body is really important.
Yes. Then we have to Anna the question. What do you see the opportunities to see in the future of those with NCDs and how this promote co-production?
Well, I'm going to pick up on what Laura said about AI. I think that's our opportunity in a really, really big way. And I think it's exciting, actually. The opportunity we've got to enable our healthcare professionals to step away from the paperwork and the administrative burden that AI will provide is extraordinary, because what they're then able to do with that time, of course, is to spend it with patients. And I haven't met a healthcare professional yet that went into that career thinking, I don't want to spend my time with patients. That's exactly what they want to do. So, and that's what patients want as well. I remember thinking when I was only 19 and diagnosed with Crohn's disease, why are these doctors not with me? Why are they spending so much time on their computers and filling out paperwork? And of course, then moving on to work for the regulator, I realised that's exactly why, because they've got standards to meet. But I think AI is going to really enable healthcare professionals to step away from that burden. as Laura said, you know, I think Linda.
Answer to anything.
Is Linda?
Linda.
As Linda said, sorry, darling. I think there's a risk. There's a risk, isn't there, with AI as well? And we need to be really careful with that, because for patients, having mechanisms that potentially take away the human nature of care, I think is something we need to watch and be very careful of, because that human interaction is really, really important. As we've all said, we want to feel that people care for us. A computer can't do that. An AI model can't do that. Not yet, and I hope never will be able to, because there's something incredibly powerful about personal connection, which is so important to all of us.
I agree with you. Everyone is coming with fear, with doubts, and just simple communication brings something very much cost-effective healthcare. So we are at the future. So Lucy, tell us, look into the future. What is one change of innovation you would like to see in the way we approach chronic diseases care, whether in policy, in practice, patient engagement, or healthcare delivery?
Okay, so to be able to bring the future, I need to evaluate the past. And considering that I started as a patient and patient representative, and now I have the opportunity to be part of the regulatory office and to be able to approve new medicine coming to the market, I realized that it's not true that we don't have enough money in the system. We do. In my country, we do have enough money in the system. The problem is that the money is not properly distributed. We have so many ineffective processes, standards, evaluations, which are actually taking the money for the treatment. So I would say that we need, and the government need, skillful managers who will be overlooking the processes and looking for the gaps. And we need to start with the patient registry, because if you think about it, a lot of NCD patients are having comorbidities. And because we don't have centralized systems and the patients are going from doctor to doctor, and they're spending the time repeating what are they going through, what they've been through the past, the whole family history. That's also how the system is losing money, and the patients are getting desperate because they need to repeat themselves all over and again. So I would start with the processes to look what we are having in the pipeline right now with the new government, which is always a hassle because we are starting with the new government. We never have a healthcare minister who actually finished his term. So there is somebody else stepping in even before the end of his term. So it's like Sisyphus work, but we are all, I think, doing the same stuff and trying to improve the environment as a complete.
Yeah, good point. We have Linda from the US, and I think she can tell us what lessons can Europe draw from the US advocacy in turning lived experience into prevention-driven, patient-centered policy, and how can technology and AI help strengthen engagement and care delivery.
So what I think we have to share from the US to the EU is we've gotten it all wrong. Seriously. And you have led the way for change, for a ban, to reduce chemical exposure, and a lot of aspects. I think what's important is that a patient's story is not just a story. We become experts in the field. And I think supercharging patients to feel more comfortable being part of prevention and policy is very important to research for a cure and obviously care management. So ADO has done a lot in 20 years. Obviously, we still have to ban asbestos. My husband died 3 years after his surgery, and our work continues today. And awareness is a key part. I know this organization also believes in awareness. So I think coming together, collaboration, communication, accountability are all extremely important. And we have built a chatbot on our website, of course, and an app to use as a tool. So using technology has to serve in the next generation. And I think with everyone being so busy, and it is difficult, communicating succinctly, concisely, accurately to possibly an international audience or someone in the US who's just plain distracted is really important, is to streamline messaging. So I believe in prevention 150%, and I also believe in collaboration.
Thank you very much. We three last question from online. So we have more than 300 people who participate in our conference. And the first next question from audience is, from your experience, what structural barriers still prevent patients from meaningfully contributing to regulatory decisions, and how can we address them through policy or practice? Who wants to answer?
Wow. I've got the mic, so I'll start with a very quick reflection. I think for me, the biggest problem we've got is leadership and role modelling. I've mentioned it more than once. Unless our leaders at a government level, at a provider level, start to really role model the importance of person-centred care, it's not going to happen. And it's really hard for them because they are struggling for airtime in amongst all the other priorities that healthcare settings have to focus on. But I think until we get that leadership, we're not going to move forward with person-centred care. For ISQA, I go to the ISQA conference every year, and there are, maybe 2,000 people that attend that conference. And every year, the challenges are the same. We're not moving forward at the pace we need to when it comes to person-centred care and co-production. And until our leaders focus on it, I fear that we're going to have very slow progress.
That's a really important question. I think that patient empowerment is critically important. If we can educate a patient that it's okay to question your physicians and your treatment plan, it's okay to go in with questions or record a conversation if you ask for permission with your doctor. To empower a patient with knowledge and tools can save their lives, save time, and the quality of life can often be improved.
I would say that when we started, we were struggling for recognition, that we wanted to be taken as a professional organization, professional advocates. I would say that we achieved, even on the European level, we achieved, but now we are struggling for money because they got used to us working for them professionally, but for free. And many of us, as you are sitting here, we are not full-time patient advocates. We are having civil lives, civil careers, but they still expect us to do the work for free, and we are doing it for a certain level because we want to help. We want to improve the environment. But when I am receiving an offer for government, hey, we have this new fund, we really need to think it through how we are going to use it. I'm like, okay, but you have a group of governmental officials who are paid for taking care of that agenda, and you are asking 6, 7 patient advocates to do this for you for free in their free time. Come on, that's not fair.
Yeah, this patient advocate should be more heard of the governments. The next question is, how can regional networks like WPA Europe strengthen collaboration between patient groups and national regulatory agencies to ensure lived experience is constantly valued?
I just want to I need a break.
You need a break. Okay, no problem. Well, lived experience is monumentally important. And I think collaboration where we reduce all barriers and obstacles to preconceived ideas is important so we can all come together. I think listening to Penella talk about World Health and WHO, there's a lot of opportunities for us to connect and share and to move policy and recognize that it's time to embrace change.
Yeah, I think I mentioned it in my presentation. There is a need for us to come together, really. There's too many different organisations and charities trying to do the same thing. Certainly, Hussein and I work together at ISQA, and we've built a really good relationship with the World Patient Alliance since we met 5 years ago. At ISQA, we're building relationships with the World Health Organization all the time, and I see we've got the World Health Organization represented here at this meeting as well. So I think we're going in the right direction, and more of that collaboration, as Lynn said, is really key.
Yeah, we have one question which I think is very interesting because they asked, what safeguards do you believe are essential to make patient engagement in regulatory processes inclusive, especially for underrepresented or marginalized communities? Lucy, it's for you.
Okay, so I would say that I'm coming from Czechia, and in Czechia we are considered to be a best practice because we have advisory patient board under the Ministry of Health. It's 26 patient advocates who are working directly under the Ministry of Health and advising on multiple issues. It was a bumpy road because in the beginning, the patient advocates, they were advocating only for their primary diagnosis, which I always consider it's not completely right because we are there to improve the whole system, not just to fight for our patients. We also have the regulatory committee for rare diseases, which is approving new medicines or advising to the Minister of Health if there should be admitting under the reimbursement system. So it's a unique opportunity because we have the same voting rights as the people from the ministry, as the doctors and as the insurance representatives. So I would say that we have the path. We have the communication system. We have the access to the governmental level. And the safety, well, let's make it legal. We are, it's created by the law, by the paragraph of law. So that's the easiest way then when the governments are realizing that they really need us, that they really need access to the patients. And I would say it's safe because it's legally approved.
Thank you. Now it's your role. So if somebody has any question to our panelists.
You keep it.
Yeah.
That's great. I have brought a very interesting, important point on the patients and their care and decision making. Many healthcare systems are paternalistic or they don't have enough time, like many countries Spain, they have like 5 babies in primary care. So they perceive, even though, doctors or healthcare professionals, they love the model and they're humans and they would love to implement it, they think it's a time drain, right? We don't have enough time, but as you say, if we bring the data actually and empower and monitor patients who spend less time in the healthcare system, right? Because they have less hospitalization, they can self-control at home better and with their caregivers. So I think that the problem here is that we don't have data, right? Maybe we have data for Europe and the US, but we will not have for Africa, Asia Pacific. So I think if this is something maybe we can work with WPA in making like a small study on the time invested in the healthcare system of a patient with a PCC model versus another patient. I think that will be a great research that we could carry on together to prove. So we have data to prove like this works and actually this saves you money and time.
If I can also add something to his question about the time at the doctor. I am from Poland, and for example, in my country, very often the doctor only has 5 minutes for a patient. So sometimes it looks like the patient is coming, then what prescription and go on. And for NCDs, it is so crucial that we have time to explain what is the disease and how to make this compliance with the patients and how to explain everything. For example, in Germany, there is somebody from Germany. So in Germany, you have 17 different national health funds who pay for the treatment. And if the doctor didn't dedicate 15 minutes, then the patients can complain, and 3 complaints, the doctor can lose the contract. So this is maybe too ridiculous, but it shows that a doctor should give more time, more attention, and more more relation, more attentive for the patient.
So oh, yeah. We should do this one too. It all works. Holding the doctors responsible, I think, is appropriate, but I also think having patients understand the timing that physicians face is also important. To come prepared, to have your notes, to understand, to feel comfortable to ask questions if you don't understand, because that will make you a better patient and the physician a better care provider, I think. We have to balance that.
I was going to say I can probably summarize my medical history. I think I've got it down to about 2 minutes now, and that's 20-30 years of of medical history to summarise. So I agree with you completely. We need to be able, as patients, to go in and very quickly provide an appraisal of where we are and what we need. So it is always two-way. And there is quite a lot of research out there, but I agree with you that we need to ensure that that research is region-specific as well, so that we can really get the message across. Sitting here today and saying X, Y, and Z that's not relevant to different parts of Africa or Asia isn't going to help anyone. So I think we do need to be a bit more focused.
Okay. I want to ask a question to Lucy. You raised a very important point for the volunteering organizations that represents patients, and the government always expect us to collaborate by free. But in reality, our patient organizations as salaries to pay to our experts that help me as a volunteer to perform and give correct opinions. And what happens is we don't feel from the government, especially from the health sector, any understanding about the funding of the patient associations. What are your thoughts about that?
Can you please tell me what country are you coming from?
Alexander from.
Okay, great. Well, I think that it clearly shows the division that we are from different countries, and the attitude of the government towards the patient organization, it's not all the same. We are also, my association, we are a group of volunteers, mostly patients or the caregivers. We have free partial jobs which are paid by the work office because they are secured for the disabled people, and all the other peoples, which is 20 plus, are working for free. And they're having their civil lives, their careers, and they're using their holiday leaves to do the advocacy work and to help other patients, even peer-to-peer support. What we are trying to do for several years, we are pressing the government to release the money, because now they have a fund which is supposed to be released between the patient organizations to secure also the funding of the day-to-day operations. But how it's going to end, and how is it going to end eventually, we will see, because they're determined to give the money for the education, they're determined to give the money for the specific projects, but they don't realize that the people have to be leading the projects, that the people need to provide the education, that the project's not going to make itself. So that's an ongoing issue, and I think that we are all facing it, and there is no easy solution for that. We just need to push them even more to realize that they really need us, and they really need to help us to work on the day-to-day agenda.
Yes, thank you. If somebody will ask question, please tell always name and organization or country. You know, we are like a small family, 30 people. I wish tomorrow everybody knows, oh, this is Alexander, this is Penila, this is Konstantin, Yolanda. So I think it is easier. We have 3 questions more. Penila, you and Andrew after.
Thank you. I just want to add to the topic for the seminar session. Maybe, I mean, it's not all. It's a good beginning always. I would say with collaboration and so on. And so I was also speaking about before. But we need also action. And it's really, we do have it included in the Healthcare Act, major legislation about healthcare, about patient-centered care or person-centered care. And also, it's a law added to the Healthcare Act called actually the patient law. The patient legislation is the status that you have your own free will. You can take part of your medical notes, you can take part of your treatment and so on. You have an obligation also, as we heard it, to take care of yourself, of course, but it's stipulated that you have all the rights to also be given all the information or deny information. If you don't want to know, okay, you can tell the doctor, and also turn offers down to treatments if you like to. So I think it is about also to take action for really things that matters, you know, that when we're working together, healthcare professionals, patient organizations and legislators, it will happen something more because this thinking about person-centered care should be included in everything that is we're doing in healthcare. So it's not only a thing that should happen when you comes to the doctor and independent of what time he or she gives you, it's about the thinking. It's about thinking how the patient works and the collaboration with the healthcare giver and also the patient. And more close ones, relatives around, family, and so on. So that's my recommendation to work for having included in your national legislation about healthcare.
I would like to touch on our colleague from Portugal because your question is really important. As organizations, we never have enough time or money. I call it kitchen table advocacy because that's where I do most of my work, right? With a headset on, walking in my kitchen and thinking all the time. But I think collaborating with other people, it doesn't have to be the same disease, but it could be something similar. It could be in a different country. I think building an arsenal, your toolbox of what you do really well and having a one pager. So when the government is looking for a spokesperson for that disease or that topic, they can find you because it is through visibility that it will help you, I think, move your issue forward with policy and prevention and ultimately funding. We're always strapped at ADIO. I never have enough time or money. But building that arsenal and connecting with other like-minded people and members of Congress has greatly helped me. And I'd be happy to give you some suggestions or talk with you later.
Question from Anna. Thank you.
Hi everyone, thank you for that. My name is Amanda, I work for the Synergist. The Synergist is an NGO based in Belgium, in Brussels. Thank you to all three panelists, and Anna, I really liked your talk as well, connecting the dots between person-centered care and NCD work that's happening at global level. This is getting slightly ahead to tomorrow's session, but I can't resist to already ask, how do you see those dots also connected to the social participation resolution that was unanimously adopted at last year's World Health Assembly? And the reason why I'm asked is that we have a lot of public questions coming up about the funding of patient engagement and the funding of patient advocates who actually have to do volunteer work. But that resolution calls for resourcing. And even though it never mentions the word patient in the resolution, it covers everything you already discussed. So I'm wondering if that's an additional connecting of dots that we can do to help unlock the financial question.
So I think this comes back to the question we were asked earlier about evidence and how we build the evidence base, actually. Because for me, there's no doubt that there are financial incentives to doing more co-production and person-centered care. There are lots of other incentives as well, but there are definitely financial ones. And there is something about hitting the right mark with the decision makers. And with the greatest will in the world, having worked in central government, in the Cabinet Office and at the Department of Health in England, money talks. And so we need to build that evidence base. We need to ensure that they can see how it's going to save us money. And I think only then will we be able to make the progress that we need on co-production. And I've said before, but it is really important. We're fighting for airtime. And I can only speak for my own country, but we can't get people through the emergency department in less than 8 hours at the moment. People are sitting there for hours and they're dying on trolleys. So when you're then asking for doctors to co-produce as well against that sort of context, it's really hard. So I think your case has to be extraordinarily compelling, and it does come back to money.
It's not a question, but I think that seek for multimorbidity, not one disease. It was multimorbidity, and system of healthcare in many countries was established, rebuilt in the second half of 20th century, when existed separately of diseases. And this system is Jesus-centered system. And we now must rebuild the system for integrated system, because this existing system is reintegrated, integrated system and patient-centered, not disease-centered system. Some countries, for example, Belgium or Denmark, organize clusters of integrated system, and they changing this system for specific epidemiologic era of epidemiologic transition, where exist multiple diseases in multimorbidity diseases, not separately diseases. It is problem, I think, in the organization of healthcare system.
You're right. So, Andrew?
Yeah, can I shortly react on that one? Because that's what I said several times, that we need to step out of our original diagnose, and we need to act as patient advocates to work on the whole system, which I totally agree was based on the patient diagnosis. But now I would say the trend is towards the prevention, to the healthy society in general, to the healthy lifestyle, which is also the well-being of the mental wellness. So I would say that it's not that bad as we are thinking it is, because we have the trends in, and the society is evolving towards that direction.
I was just going to say quickly, integrated care is really big in the UK as well. We've just changed our legislation to ensure that integrated care is the future. We've also got legislation, like Penella was saying, to ensure that patients are part of our regulatory model, but also our patient safety model. So we're moving in the right direction. But I would say we need to be really careful with legislation, because it can provide a kind of, if we've got it in legislation, it's done. And that's not the truth. We then need to bring it to life and ensure that the reason that we created the legislation in the first place is lived out in reality. So, but I totally agree with you on the integrated care model. It's essential that we have every service working around the patient, rather than the patient having to go to 10 different places. It doesn't work. But thank you for the comment.
Thank you for wonderful discussion. As we close this session, I want to share 3 recommendations for patient organization across Europe. The first one, we must have a patient partnership as a permanent part of healthcare is designed and governed. Patients should not be invited to take to the table only when decisions are already made. Their experience, their expertise, like we heard from our panelists, it starts in hospital, in national healthcare committees, and it should be patient-centered on all levels of treatment. Patients share responsibility, and they should have power to talk to professionals. And they are also should be consulted not after the fact, but before. This is the first. The second, we need to move beyond words and start measuring the whole patient-centered care. What does it mean? And many systems claim to be patient-centered, but they are not doing it in fact. Patient organization should lead the whole transparency and the whole system and partnership. And the third one, finally, the collaboration across Europe is essential. The challenges of NCDs cross borders, and should the efforts be flexible, equitable, and responsive. By sharing these lessons by our panelists, we know how to build better health system, how to adapt that people work really together and beyond all borders. Thank you for our panelists. They were great.